Thank you for joining. We will start momentarily. Thank you for joining. We're still waiting for people to log in. I can see the participant numbers ticking up, so we'll wait just a couple more minutes for them to join. Thank you all so much for joining our webinar today. Care and Choices at the End of Life, Hawaii's Our Care, Our Choice Act, a focus on oncology and general medicine. My name is Sam Trad. I am the Hawaii State Director for Compassion and Choices, and I will be your moderator today. This webinar is available for continuing education, and I have to read right now. I need to read the requirements for it just to make sure we're compliant with the continuing education credits. In support of improving patient care, this activity has been planned and implemented by Hawaii Pacific Health and Compassion and Choices, Hawaii American Nurses Association, and NASW Hawaii Chapter. Hawaii Pacific Health is jointly accredited by the Accreditation Council for Continuing Medical Education, the Accreditation Council for Pharmacy Education, and the American Nurses Credentialing Center to provide continuing education for the healthcare team. Hawaii Pacific Health designates this live webinar for a maximum of 1.5 AMA PRA Category 1 credits for physicians. Physicians should only claim credit commensurate with the extent of their participation in the activity. Hawaii Pacific Health designates this live webinar for 1.5 contact hours for nurses. Hawaii Pacific Health is accredited by the Accreditation Council for Pharmacy Education as a provider of continuing pharmacy education. This activity is accredited for 1.5 contact hours for attendance at the entire CE session. As a jointly accredited organization, Hawaii Pacific Health is approved to offer social work continuing education by the Association of Social Work Boards, approved continuing education program. Organizations, not individual courses, are approved under this program. State and provincial regulatory boards have the final authority to determine whether an individual course may be accepted for continuing education credit. Hawaii Pacific Health maintains responsibility for this course. Social workers completing this course receive 1.5 continuing education credits. Hawaii Pacific Health is accredited by the American Psychological Association and designates this live activity for 1.5 continuing education credits. Continuing education credits for psychologists are provided through the co-sponsorship of the American Psychological Association Office of Continuing Education in Psychology. Hawaii Pacific Health maintains responsibility for the content of the program. In order to claim CE credits, please note that in order to receive these credits for this offering, you must claim credit commensurate with the extent of your participation in the activity, complete and submit the evaluation survey that will be emailed to you within 1 week of the offering. Speakers cannot claim credit for their own presentations. Your CE credit will be immediately available to you upon completion of your evaluation. Yay. Thank you so much to everyone who has worked so hard to put tonight together. We are so appreciative of all of you. Thank you all for joining. We will be taking questions at the end of today's presentations. So at any time you can type your question into the box on your screen, and we will get to as many questions as possible at the end of the session. Please note that we are copying and pasting questions into a Google document so we can put them all together. So if your question is dismissed, don't be nervous. It doesn't mean we're not going to answer it. So again, you can ask a question anytime by typing your question into the box on your screen. This webinar is being recorded, but don't worry, we can't see you unless you're a panelist. Learning objectives. So I talked a little bit about how to get the continuing education credits. Today in this webinar, we will be reviewing clinical competencies for participating in medical aid in dying and the requirements of the law under the Our Care, Our Choice Act. We will be examining nurses, APRNs, physicians, mental health professionals, the team-based approach to patient-centered care, the role of pharmacists, their experiences and issues in relation to medical aid in dying, as well as providing an update on the Our Care, Our Choice Act numbers for Hawaii. Compassion and Choices is a nonprofit organization. We've been around for a while, and we work to improve care, expand options, and empower everyone to chart their own end-of-life journey. We are very honored to be joined today with the following speakers: Susan Amina, a nurse practitioner from Kaiser Permanente; Dr. David Grube, the medical director for Compassion and Choices; Dr. Brian Goodyear, a clinical psychologist; Jake Blechta, a pharmacist with Elix RX; and hopefully Dr. Charlotte Sharfin. She is an emergency physician on Hawaii Island, and she's on call today, and she was called earlier. So we're really hoping she'll be back in time to talk about her experience on the Big Island. Who is in our audience today? We're going to do a quick poll to find out who is in our audience. So if you can take a minute and let us know your primary role. Are you a registered nurse? Are you an APRN, a physician, a pharmacist, a pharmacy technician, a social worker, a licensed clinical social worker, or a psychologist? Please let us know. All righty, I think just about everybody has voted. Do you want to show us those results? All right, it looks like about half of you are registered nurses. We have some APRNs as well as a few other physicians, pharmacists joining us today. Thank you. Did everyone, I hope everybody saw that. Okay. All right, where do we start? Well, without further ado, I'm going to hand it over to Dr. Grube, our medical director.
Thank you so much, Sam, and thank you for the opportunity to share again with you this information. I'm a retired family physician in Oregon. I did put on my Aloha shirt so I could pretend like I'm being with you, but we are having big floods today, and so I'd rather be there with you than here in Oregon tonight. So we're going to begin by something I think is so important to share, because this is something that I've always recognized, and yet it still is a problem, and that is when a patient brings up the topic of medical aid in dying as an end-of-life option or choice, hopefully that can be considered their first request. Whether or not they ever go through with anything, doesn't matter if they decide not to do it, but if you can think about entering this into the medical record, either as particularly if you're not a physician, being able to get a physician to put this, it may make a huge difference for the patient over the next few weeks. And we're going to get into that in detail. And we're going to talk about how to respond to a first request, but every story is different. Every individual who thinks about this has context. And that all needs to be explored as we're going to decide. But very importantly, if this individual is within just a couple days of dying, it's really important for them to understand that this won't be an option for them, because in Hawaii, you have a 20-day waiting period after the first request before the second oral request can be given. So make sure that you're honest with the patient right from the start. And also, if they're not able to self-ingest, if they're not able to take the medicine in themselves, we're going to talk about that too, they're not a candidate. So right at the beginning, it can be helpful for the patient for you to explain to them, if it seems like they just have a few days left, or if they haven't been able to take anything in by themselves, self-ingest, they're not eligible for aid in dying. Next slide, please. So the best thing you can do is be prepared, and that's why you're here with us this evening, to learn as much as you can, to ask questions, and to share your concerns and issues with your peers, to explore your own personal beliefs in regard to this topic, and to work already with some consulting with your peers, because this is something that's a team effort. It's not something that can be done just individually by one person. Why is the individual asking about medical aid in dying? We can't know unless we listen to them and explore and tease out all the things that are their problems, what are their wishes, what are their goals, and it's so important to get them involved in hospice if possible, if at all possible. It's hard to imagine one of these individuals who's talking about this topic and who's terminally ill and suffering, that they would not be in hospice. It's hard for me to imagine that. And I did help patients over the years before I retired, and 100% of the patients that I worked with ended up in a hospice enrollment. So I put the word listen there several times because that's the most important thing that we can do as we explore what their needs and concerns are, and as we counsel them through this process. The most important thing that I want to highlight here is professional integrity. Remember, being a professional means putting the patient first. Whether or not what our beliefs are, it doesn't matter. Putting the patient first is what really, really matters. And so if this is something that we could not, do not believe in, or it's not something we could support for the patient, it's very important to refer this patient to alternative healthcare providers to discuss end-of-life options. All right, I think we'll go to the next slide, and I think, Susan, that's going to be yours.
Yeah, so good evening. Yes, my name is Susan Amina. I'm a nurse practitioner at Kaiser, as well as a cancer care coordinator. And to start, how might the nurse respond to patient requests? Certainly being prepared and understanding the law is paramount. I'll share with you, we actually have an FAQ that gives the patient some introductory information that we've asked nurses and medical assistants or whoever actually is working with that patient and has that question to at least start to give out that FAQ for information. If indeed they want to go forward, it would be important for you to talk with a physician before that patient is seen by that physician, so the physician's aware. And then, exploring reasons for patients' request. I have to say that probably most often it has to do with control. So really the need for autonomy and control over end-of-life situation, I think, is probably the majority of reasons that patients share with me. Reviewing all of the end-of-life options, which we're going to talk a little bit in a bit, but even in Hawaii, not only hospice, but many of the hospices have something called integrative care, where you can actually be on, for example, palliative chemo or radiation and be in that program. It's a little bit more of a slimmer program in terms of, for example, let's say it's an NP and a social worker, and doesn't offer as many services, but at least it's a step approach to perhaps hospice. And then just in terms of, in the chief complaint reporting to the physician, I know at Kaiser, what we'll often do is we'll put advanced illness coordinated care, and then the comments we'll put made for reason of visit. So just, if we can go to the next slide, I think you'll see that FAQ. Yeah. So again, this is a pretty broad one-page sheet that just essentially goes over a little bit about what MAID is and eligibility, a little bit about, is this considered suicide, which of course it is not. What if I change my mind, etc. So this is just a nice introduction to give to the patient when they're approaching any healthcare professional with questions about medical aid in dying. Next, Dr. Grube. Oh, I think you're on mute, Dr. Grube.
Yeah, excuse me. Just remember that medical aid in dying is only one of many different options that we've talked and mentioned about palliative care and hospice, which are so important. But there, because this is, we're dealing with patient autonomy, as Susan mentioned, and control, we would need to go through this palette and explain to the patient that they can continue to pursue life-sustaining treatments, they can refuse treatment, they can discontinue treatment. Continuous deep sedation, also historically known as palliative sedation, is an option that's not too often used and is a little high tech and is not indicated in too many situations. But that's to control severe symptoms that are too miserable for the patient. And then, of course, voluntary stopping eating and drinking is another topic for another time, but it is also an end-of-life option. Next slide, please. So medical aid in dying is simply this. It's a practice where a mentally capable adult, that means somebody who has capacity to understand what they're doing, with a prognosis that is terminal, 6 months or less to live, which is similar to hospice, can talk to their physician about getting a prescription for a medication that they can choose at their volition to self-ingest to end their life in a peaceful way and end their intolerable suffering. So that's medical aid in dying in a nutshell. Next slide, please. The individual has to be an adult and has to be a resident of Hawaii. As I mentioned, they have to have 6 months or less to live, and they have to have capacity. So at the very beginning, we'll say, you know, if someone has dementia, this is not an alternative for them if they cannot understand informed consent. And if they cannot self-ingest, or there's not a workaround for that, and we will talk about that in a bit, they are also not eligible. Next slide, please. So the start of the process. One of the things that I used in Oregon as an aid for me and as a help was the form that we are obligated to complete for the state of Hawaii and the state of Oregon, because it kind of goes through every step that's necessary. And if you go through the form, then which is not complicated, then you're making sure that you're abiding with the Our Care, Our Choice Act itself. Next slide, please. There are two physicians involved. There is the attending physician. That's the doctor who will be writing the prescription and who has a primary responsibility for the patient care, and a consulting physician. There is legislation that's being considered in the state of Hawaii to expand this to include advanced practice registered nurses. I'm going to have Susan do the second part of this slide.
So, thank you, Dr. Grube. So in terms of the navigator, you know, again, whether it's a nurse or a social worker, it's important, I think, to be, as Dr. Grube had mentioned, being very non-judgmental in terms of support. And I think of this when I'm working with patients that they should not have a sense of my opinion, essentially. Obviously, if I was strongly against it, I probably wouldn't be in this role, but nonetheless, it should be very neutral in terms of how I'm presenting the information. You know, we're really fortunate at Kaiser to have a closed system and to have a couple of navigators. It makes it much easier than I know often in private practice and often on the neighbor islands, you know, they struggle with care coordination. But there is a lot of coordination, appointments that need to be made, you know, based on the law. There's Department of Health forms that we collate. And then actually after the patient is given the medication, we actually do telephone follow-up on a fairly regular basis. And, you know, I think upfront to be aware of the patient's condition timeline, you know, because Hawaii does have that 20-day waiting period, It's essential, especially if they're, appear to be very ill, that we move as quickly as possible. So not unusual, and, with the help of our providers, who are very flexible, that if I receive a referral today, that I sometimes can do a same day or tomorrow that verbal request, number one. We work closely with hospice, and even today, actually, I called a couple hospices just to let them know that I am the navigator in terms of MAID, and just if they can keep me informed in terms of how the patient's doing. And then just being accessible for questions and concerns. I try to, be available through my office number as well as my cell number, and encourage patients to call me whenever they have any questions or concerns. And then just, overall being a patient advocate. I think how it affects, I was thinking in terms of how does it affect oncology specifically? There's a couple thoughts I have. One is certainly in terms of head and neck cancers, you often have the possibility of patients having difficulty swallowing. Not to say obviously with ALS and Parkinson's, but definitely that plays a role. In addition, I think we've talked in the past about red flag indicators. Where are there red flags in this history where it might promote a longer death? So certainly that's been seen with pancreatic cancer, colon cancers, and liver. So that certainly plays a role in terms of oncology. And then lastly, as I said, if they are on a palliative, at least in Hawaii, if they're on a palliative chemo or radiation regimen, they're not eligible for hospice, but some of the hospices do have a program called Integrated or Supportive Care that you can use as a step approach. So they could be in that program, and then when they stop radiation or chemo, then can transition into hospice. Next slide.
I just want to jump in and say, Susan, everything you said, we hear from patients and their family members all the time that they never would have gotten through the process if it wasn't for nurses and patient navigators to help them along the way.
Yeah, it's really overwhelming. And I think it's just trying to separate it out and do step approach, and knowing that I'm going to be the one that actually is going to follow that timeline, the letter of the law, and help them in terms of reminders or whatnot. It's very difficult to just, here's what it is and let go of it for that patient. In terms of Kaiser, and we're a little bit unique, there's some pros and cons, I think, here, but typically what we do is we do an educational appointment first. So in the case, we've had some cases where the patient has expressed a verbal request to a provider before the patient education, which is fine. And we typically will abide by that, especially if the patient's very ill. Ideally, we actually want to do an educational appointment first. And then, as I say, very quickly, we get to schedule that first verbal request, typically with Dr. Miller. We have designed documentation templates, which are really helpful, which I think we'll show you later. So it really helps the providers to clearly go over all the parameters that are outlined in the law. Again, making sure it's an informed decision, it's voluntary, et cetera. And again, in the community, again, it's typically the first verbal request comes first and then the education. So again, we're aware that we certainly don't want to put up any barriers or delays. We just try to be cognizant of the fact that to move as quickly as we can. And again, if a first verbal request is given, for example, recently to an oncologist, we'll go with that and then fill in education afterwards. Next. So this is just a template. I know it's kind of wordy, but you just get a sense. It's really easy for example, at Kaiser, the attending physician can basically just go through this and clearly outlines that they've got to address diagnosis and prognosis, eligibility, hospice status, palliative care, pain management, et cetera. But it's just really nice for them to be able to document fairly quickly and touch on all the points that are required. Next. Dr. Grube, you are muted.
Thank you. So again, There are forms that are needed to be completed in all states, and Hawaii is not unique in this regard, but they're helpful. The forms can be helpful because, as Susan was mentioning, there is a series of things that need to be done. And this is just a brief example of the Hawaii Department of Health form. Next slide, please. Determining eligibility. Now, as I mentioned, and as Susan mentioned, if the person is pretty sick and they make a first oral request, we don't have to determine their eligibility yet. I mean, that can be determined later, but we do need to document in their chart that they are making this first request. And if the eligibility then doesn't pan out, we can deal with that later. But to delay documentation of a first request as we determine eligibility, I think is unprofessional, really. So we determine their diagnosis and prognosis and survivability, their capacity, the fact that this is volitional, they're not being coerced. And of course, this subset of people are very focused and know what they want. And I know people who are opposed to aid in dying always worry about coercion. This is not the group of people you're going to coerce to do anything. These are very independent-minded people. The ability to self-administer, and of course, the residency and age requirement. Next slide, please. Again, the documentation of the first oral request, I kind of wish that was the number one instead of the one of the later parts of the form, but that's a very important thing. So in Hawaii, the Our Care, Our Choice Act has these components. 2 oral requests to the attending physician separated by no less than 20 days. This does not necessarily have to be in person. Telehealth is allowed, actually in all authorized states except Vermont. But the voluntariness of the patient's request needs to be clear, and on occasion that might not be possible in a telehealth visit. In Oregon, it had been 15 days and now it's been changed. We don't have a waiting period anymore if the person is rapidly dying. Because we were recognizing that almost a third of patients who began the process did not live through the 15-day period, and Hawaii has 20-day periods. So again, you'll hear me saying again and again, it's so important to put the first oral request in early. They need also to see a second physician called the consulting physician, and the consulting physician can make this appointment via telehealth. And they have to have a written request as well. And this is signed by 2 witnesses, one of whom is unrelated to the patient and neither of whom can be on the healthcare team. Next slide, please.
All right, everybody. And I just want to remind you all that you can ask a question anytime by typing your question into the Q&A box, and we'll get to as many as we have time for at the end. So everyone, please answer this poll question. The patient only needs to make 1 request to their physician in order to proceed with medical aid in dying. True or false? We'll wait a minute as everyone weighs in. All righty. Results, please. Most of you got it. The correct answer is false. The patient only needs to make 1 request. I already read that part. That was the question, but it is false. You need to make 2 oral requests at least 20 days apart, not necessarily in person, and you need to make 1 written request signed by 2 different witnesses. All righty, next.
So then there is the consulting physician. We had the attending physician, and the consulting physician's role is simply to confirm the eligibility requirements, and also may refer the patient for a mental health evaluation. We're going to get to that in a second. And then complete the forms that are necessary. So the consulting physician's role is simply to confirm the eligibility requirements, examine the patient, of course, if they have not already. Next slide, please. So as I mentioned about the attending or prescribing physician and the consulting physician, and then in Hawaii, you are unique as a state in your aid in dying bill or law, in that a psychiatrist, a psychologist, or licensed clinical social worker must evaluate every patient to affirm capacity, mental capacity. And we're going to talk about that with Dr. Goodwin here, with Dr. Mental blank for a second. Anyway, in a second. Next slide, please.
It's Dr. Goodyear, and we also work with the Dr. Goody on the Big Island, and Christina Goodwin. There's lots of good people that we work with.
They are good, and I have a local psychiatrist whose name is Dr. Goodwin, so that's why I get stuck. Anyway, these are the forms that the consulting physician completes, and these are available and can be downloaded. And again, I think they're very, very helpful. And documentation is important, but it's also can help quite a bit. So I'm going to actually ask Dr. Goodyear to come in now and provide some information by perhaps telling us a story.
Thanks, Dr. Grubb. And thank you to all of you for attending this. It looks like we have a really good turnout. As Dr. Grubb said, the mental health evaluation is unique here in Hawaii because the law requires all patients who request medical aid in dying to go through a mental health evaluation. The way the law words it is a little bit unusual, I think. The law says that the patient must be referred by the attending physician for, quote, counseling. And counseling is defined as one or more consultations with a licensed psychiatrist, psychologist, or clinical social worker. I tend to look at it as not so much a counseling session, but more an evaluation to determine a couple of things. And according to the law, the evaluation has to determine, first of all, that the patient is mentally capable. And secondly, that the patient does not appear to be suffering from undertreatment or non-treatment of depression or other conditions which may interfere with the patient's ability to make an informed decision. I thought I'd say a little bit about the typical process that I go through. Most of my work has been with Kaiser. I've done a few evaluations outside of Kaiser, but most of them have been outside of Kaiser. And what happens is that I get a contact from one of Kaiser's patient navigators, that's either Susan or Jody, asking me to do a mental health evaluation. But by the time I see the patient has already seen the attending physician and sometimes has also seen the consulting physician. So frequently by the time I see the person, the patient has already seen a couple of different providers, and both of those providers have documented that the patient does have the mental capacity. So my role is really to just confirm that. And in most cases, that's a relatively straightforward procedure. There are a few cases that perhaps we can talk about later if we have time, where it's a little more complicated, but usually it's a pretty straightforward procedure. This is the Department of Health form that we have to complete, the counseling provider's statement of determination. And it's a very straightforward form. Just has the basic information, very easy to complete. And this can be downloaded from the Department of Health website. The components of the mental health evaluation, let me just say we're going to be doing a presentation next month on the mental health side of things more specifically. So I can go into more detail about it at that time. But the components of the evaluation, the things that I go through, first of all, Susan or Jody will send me the relevant medical records, which I will review. If there's any available mental health records, I'll also review those. Then I'll do a clinical interview with the patient. We were doing them in person at one time, but with COVID, we've gone pretty much entirely to telehealth. And then after doing all of that, the completion of the Department of Health form that you've just seen, and then I will write a detailed clinical report that goes into Susan or Jody, who will then forward it to the attending physician. Okay, I think that's it for me at this point.
Susan, would you like to, please, would you do the slide? Thank you.
Sure. So as I said, I'm a nurse. I work with a social worker, Jody. She's an oncology social worker at Kaiser. And I think whether you're an RN or a social worker, it lends itself to being a navigator nicely. Definitely, I have to say the social worker probably does a better job over in terms of advanced care planning and looking at community resources. But again, either way, very vital role in terms of medical aid in dying, just because it's nice to have one individual that can collate forms, make sure we're on a timeline in terms of meeting the letter of the law and communicating with the various providers. Again, important that we immediately, again, be cognizant of the timeline and try to move as quickly as possible, coordinating the appointments and follow-up. Referrals in terms of, as Dr. Goodyear said, typically we just automatically, because it is a requirement, go ahead and start setting up all those appointments at one time with the consultant as well as the mental health provider. And then supportive counseling, I have to say, I've probably spent a fair amount of time on the phone, both with the patient as well as family members. I mean, this is, obviously a very difficult time in their life. I feel privileged to be part of it. I recall one case where the wife really had a lot of difficulty in terms of dealing with her husband's decision, and yet wanted to support him. And so it's a family scenario, and have spent a fair amount of time talking with family members and as well as the patient. Advanced care planning, we always try to make sure there's an advanced healthcare directive. If not, we start that process as well as a post. And then again, do a hospice education. And I want to say probably over 98% of the patients have been on hospice. I currently have a gentleman I talked with today who's adamant that he doesn't want hospice. It becomes a little bit more complicated. I think in that situation, Dr. Miller and myself will attend that death. But the other patient was an older gentleman, and it did not go well without hospice involved. So it's really vital trying to explain to patients the benefit to them as well as to their family. And it's majority of patients are very receptive. So again, I think it's an interchangeable role between the RN and the social worker. And again, we're blessed at Kaiser to be able to have somewhat of a closed system and be able to have providers available and who can see patients and talk with patients very quickly. Dr. Group?
Thank you very much. I practiced in a private practice in a small town in Oregon before I retired, and we did not have such navigators per se. And since that concept has really flourished, it is so much better for the patient and the families and for the healthcare providers themselves. as we're working through this process. As Susan said, these are complicated cases. These are individuals and families that have what I call mud brain, which means just everything is hard to understand and take in and deal with. And so having someone who can hold their hand and lead them along the way is so valuable. Here are some more components on documentation. I have a little trepidation in putting these slides up here with all this documentation, but it for me is very helpful to make sure that the process is done in the correct way, and it is not onerous to have these forms and to complete them. Next slide, please. There is a written request, as I mentioned, and has to be signed by 2 witnesses. This is a very important concept here, to remember that all the witnesses are doing is that they are confirming that the individual is volitionally signing a piece of paper. So if the person is having difficulty finding a witness, the content of the request can be covered up, and so that because the witnesses don't need to know what this is. All they need to know is confirm that this individual is who they say they are and that they're signing it because they want to. But it's required in every state. Next slide, please. So this is a slide that kind of is a timeline for the eligibility process, and I think it just specifically defines what we're kind of fleshing out. But it is something that you can download from the Department of Health and can be helpful for you as you go through the process in the state of Hawaii. Next slide. So Susan mentioned briefly about at the time of ingestion. It's very interesting to me, and I've noticed this not only in my own practice, but also in consulting with my peers. I always offered, if possible, that I would be with a patient at the time that they ingested their medication. And interestingly, very rarely did they want me to be there, not because anything more that who they really wanted was their hospice nurse to be with them. That's who they would really like to have there. And I think it speaks to that connection that the hospice nurse so beautifully does in the last days of a dying person's life, caring for them compassionately and gently. And so it really breaks my heart when I do hear still of some hospices that do not allow their nurses to be present at the time of ingestion. But that's changing, and hospices are evolving and understanding how important this role for the nurse is. Next slide. Sam?
Sure. Thank you, Dr. Grube. Next, we are very honored to be joined by Jake Blechta, who runs a pharmacy called Elix RX and has filled many prescriptions. Welcome, Jake.
Hello. Hi. Okay. So what are the medications? There's 4 medications in the DDMA prescription. It's digoxin, diazepam, morphine, and amitriptyline. Let's see. Is my camera on?
Yes,
okay.
We can see you and hear you.
Okay, thank you. And then there's also 2 antiemetics that are taken before the cocktail, and they are ondansetron and metoclopramide. That's Zofran and Reglan. So let's see. Before taking the prescriptions, everything should just be gathered together. I think we're going over in a couple of slides, but there is no food or anything eaten before about 6 hours before taking the medications. They can take their regular maintenance medications and other medications they need, but no dairy products for sure. And just get everything together and get ready to do it. Let's see. That's before the medications. When they actually take the medications, it will be the antiemetics taken both at the same time at the starting time. And then half an hour later, they'll take a small bottle. It'll come like this. It's a 2-ounce bottle with the digoxin in it. That'll be mixed and then drank at one time, 30 minutes after the antiemetics. And then 30 minutes after that, they'll take the other bottle. It's a 4-ounce glass bottle. And they'll add liquid in there. And that's all the rest of the ingredients, the morphine, diazepam, and amitriptyline, and they'll ingest that, and they need to take it in about a 2-minute period of time to make sure it's all consumed in that amount of time. We compound this at the pharmacy. So each ingredient is available as a manufactured product, but they come as tablets or capsules. And to get this amount of active ingredients in it, they would need to crush up or open up hundreds of capsules or tablets. So we have the raw powder and we mix it together into the correct strength that they can take it easily. Okay.
All right, quick poll question, everybody. Medical aid in dying prescriptions are given to the patient after the requirements of the Our Care, Our Choice Act have been completed. True or false? All right, it looks like just about everybody has voted. All right, can we show the results? Well, it was kind of a trick question. It's not really fair, I'll be honest. Medical aid in dying prescriptions are mailed, faxed, e-delivered, or hand-delivered to the compounding pharmacy. The prescription may not be phoned in. So after the second oral request, if the patient passes, then the pharmacist can begin to fill the prescription. Back to you, Jake.
All right, so we communicate fairly well with the physicians. Normally physicians will let us know when they're going to be calling in a prescription or sending one in, and they'll let us know how it's coming. If we're going to mail it in or if they'll come hand deliver it sometimes, just a way that we can look out for it. We often recommend them to fax it in first, so we have a copy and we can start working on the prescription beforehand, so that once we get the prescription in hand, we can have it ready to dispense to the patient or mail it to them if needed. Once we get the patient's information, then we normally call the patient, make contact in some way, and then we'll ask them if they have any questions first of all, and then arrange, either pickup or getting it to them by mail if needed. We do mail to the, anywhere they need in the state. We mail to all the other islands, and on Oahu, most of the patients do pick up or have their representative pick up for them, and we arrange that while we're waiting for the hard copy. Then once we communicate with the patient that we're going to be making it, we will go ahead and make the prescription, have it ready here, and we'll once the hard copy is received, we'll contact the patient again and let them know it's ready for pickup or that we're going to mail it out to them. Okay. So yeah, this is the process of taking them in. So like I said, NPO for 4 to 6 hours before starting. No dairy or heavy laxatives, as they can interfere with the absorption of the medications. They can take their usual medications if needed. Then 1 hour prior to taking the second bottle of the DDMA, they'll start the antiemetics. So that's the 1 8-milligram tablet of the ondansetron, and then usually 2 of the 10-milligram tablets of metoclopramide, which will both come in separate just prescription vials. 30 minutes after that, they'll take the bottle containing the 100 milligrams of digoxin. And then 30 minutes after that, they'll do the diazepam, morphine, and amitriptyline. The red flags that prescribers and pharmacists should look out for: anything to do with GI absorption issues. So GI malignancy, swelling concerns, that they couldn't take the medication, gastroparesis, cachexia, bowel obstruction, tense ascites, anything that can just interfere with absorption. Cardiovascular wellness. In younger patients with ALS, they're just, their cardiovascular system is very healthy, so the medications may not work as well on them. Obesity, so patients over 300 pounds, that just has to do with, the amount of medication needed. It may not be as strong or may not have the same effect as in a smaller person, but in general, it still should work. Alcoholism, and also tolerance to opioids or benzodiazepines. So this data is from last November. At that point in 2019, we filled 72 prescriptions. I'm sorry, total filled was 72 prescriptions. That's from the start of the program. In 2019, we filled 31. In the beginning, we were doing more DDMP2, the old formula. So we did 22 of those, and that was mostly in the beginning of the year. Then in 2000, we did 9 DDMA. That was in the second half of the year. And then in 2020, we did 41 prescriptions, and it shifted to more DDMA at the 24 prescriptions. And we still did 17 DDMP2 prescriptions. The majority of the prescriptions on Oahu were picked up by patients, although we did mail a few of them. And then the neighbor island patients, opposite, we mailed most of them. A few patients had to come over here anyway and picked it up themselves.
Thank you, Jake. Back to you, Dr. Grube.
Yeah, thank you, Jake. Before you leave, what is the current cost to the patient now of the DDMA and these prescriptions?
It is $425, and that includes everything. So that if there's shipping costs, we just absorb that. So it's $425 total.
Okay.
And if their insurance, we're not able to bill insurance for it. We can supply them, and we supply everybody with a claim form that they can submit to the insurance, and they may possibly get some back.
Thank you. Thank you. And one final little caveat, about 10% of people who use DDMA have burning from the amitriptyline. So it's always a good idea to have a little sorbet around the favorite taste, and they can have that after the ingestion of the DD or, of the DMA, the second vial. And it's soothing, makes their throat cold and cool, and has a taste that they like if there's any bitterness for them. Again, after the process is completed, there is this physician follow-up form that is turned in. I think in Hawaii is within 30 days. It's important for the demographics for the Department of Health as they monitor the Our Care, Our Choice Act. Next slide, please. We can go on so we don't get overtime here. Thank you. Sam?
Thank you. So my first question, I have another poll question. How familiar are you with using telehealth, telemedicine? Have you never used telemedicine? Are you somewhat familiar? Do you use it quite regularly? Are you very familiar? Do you love it? Do you hate it? I imagine many of you have used it this year, or I guess last year, starting last year. All right, let's go ahead and pull up those results. All right, it looks like the majority of you are very familiar, but we got a pretty good range. I don't know if I already gave you the answer. So telehealth can be used as a method of communication between provider and patient for any of the components of the Our Care, Our Choice Act. True. Within provider scope, I accidentally went to the next slide. Sorry about that. So within provider scope, it's the same as face-to-face and document it as well as you document it. So you can use it, and congratulations. Most people got that 100% correct. All right, Dr. Grube. You're on mute, Dr. Grube.
I don't want to be noisy when you're speaking, sorry. Yeah, so telehealth is a mixed bag, right? And so many of these patients we know so very well, and we've been seeing them for the last 2 years as their condition has declined. And these people, it's quite easy to consider a telehealth visit. And as Dr. Goodyear was saying, with the mental health evaluations and the COVID, it's pretty much done 100% of the time. But the telehealth has been expanded in the CARES Act, and we're hopeful that it'll even be expanded more in some federal legislation that's pending now. But we need to become familiar with telehealth and figure out how that we can use it more fluidly, particularly for groups who it's difficult for them to come in. It's expensive for them to come into the office, or they're physically unable, and to ask them to keep coming back to see us in their last days is problematic. So these are just some of the things to think about in regards to telehealth, but it is legal in Hawaii, and as I mentioned, in all states in end-of-life options, except for Vermont. And they're trying to get that changed. Next slide. Dr. Goodyear.
And we'll have Dr. Goodyear and Dr. Miller, since Dr. Sharfin unfortunately hasn't been able to share us. If you can share your experiences using telehealth in action.
Yeah, I would like to introduce Dr. Miller. We are so grateful he's filling in for Dr. Sharfin. And many of you know Dr. Miller, who's an oncologist and a wonderful physician in the Kaiser Permanente system.
Okay, as far as my experience with telehealth, we started off with Kaiser doing almost all in person. And I thought it was probably important to do that in medical health, in that medical aid in dying cases, because it is such a significant decision for the patient. And I was a little bit wary when we were pretty much forced to shift to video or telephone evaluations with the COVID situation. But actually, I've been really quite pleased at how it's turned out. Most of the evaluations that I've done since COVID have actually just been by telephone. I usually try to give the patient an option as to whether they want to do it by telephone or video. And vast majority of patients have said they just want to do it by telephone. And it's actually worked out very well. So my experience has been much more positive than I thought it would be initially. And it's certainly very convenient, I think, both for the provider and for the patient in some respects. Once we are clear of COVID, I think I will sort of keep an open mind as to, depending upon the individual case, whether I will continue to do telehealth or whether I will go back to seeing the patients in person.
Okay, can you hear me?
Yes.
Sam, okay. Yeah, so I basically, I tend to 100% agree with Brian's evaluation. Starting last March, almost every attending or consulting physician role that I have played has been by telephone. And honestly, I have to say, the vast majority of those have been very successful. I've never had a case where I have been uncomfortable talking to the patient, talking to the family about their desires for medical aid in dying, or for, I guess one of the things that initially I had worries about is, how do you confirm there's no coercion? But in reality, and Dr. Grube talked about this a little bit earlier, these patients, in the 2 years I've been doing this, these patients are not going to be coerced. They are very courageous, they are very powerful, and they know what they want. So I've been very happy with that. But let me just say, on the other hand, it is not nearly as satisfying for me as a physician to not be able to see my patient, to see that patient, especially when I'm talking to them about ending their life face to face. And fortunately, I have been one of Kaiser physicians who I've completed both of my COVID vaccines. And I talked to both our navigators, Susan and Jody, and I said, I want to start going back to doing home visits with our patients, at least on the island of Oahu from now on, because I feel personally it is so important to have that face-to-face connection, and especially in the patient's home. You have so much more insight and understanding, and can feel for them and understand what they are going through with that kind of relationship. Nonetheless, I'm perfectly fine with doing telehealth, and especially on the neighboring islands. I think it's absolutely vital that we are able to continue that, because some of these people live way far away from Kona or Hilo, and it's very difficult for them to get in to see somebody, to come into the Kaiser Clinic. Anyway.
Thank you, Dr. Miller. And I'm so glad that you're able to do home visits. I know, it's a great luxury when it's possible. But I'm also glad that, telehealth is possible when we can't have those in-person visits. Did you want to say something, Dr. Grube?
Thank you, Brandon and Chuck, both so much. It reminds me of a quick little story, which I hope you'll understand how it relates. But when I taught medical students at the end of their first day, I'd always ask them, can you tell me something I did with every patient? And they rarely got the right answer, which is that I touched the patient. I think it's so important for us, if possible, to touch our patients. It's healing and palliative. And of course, in telemedicine, that has to be a virtual thing. But I know what Chuck is saying, being in their home, holding their hand and talking to them on such a huge topic or event is invaluable.
Thank you, Dr. Grube. All right, poll question time. I won't skip ahead this time. So the next question, although the law is statewide, which islands have the Our Care, Our Choice Act patients lived on? So where have patients been able to access the law? Which islands? So take a guess. Unless you've memorized the Department of Health reports, you may not know. And of course, you can pick more than one island. I'll give everybody about 10 more seconds. And I know we're starting to run out of time, because I want to make sure we have time for questions. So let's go ahead and show those results. All righty, we have some pretty good guesses there. And yes, Oahu. So although the law is statewide and you should be able to access it everywhere, not every island has had patients access the law. Most of the patients live on Oahu. However, there have been patients on Kauai, Maui, and the Big Island. I will say we have gotten a lot of calls from the Big Island, from patients who wanted to access the law on the Big Island and had problems finding a provider who could support them in the law. But it is possible. There have been patients there. All right, update on the numbers. The first 2 years of the Our Care, Our Choice Act. So we know from the Department of Health that as of October 28th, 2020, there were 63 patients who had received prescriptions, 30 in 2019 and 33 in 2020. We will get the final numbers by March. So the Department of Health is still putting together their report for 2020. Of course, there's that 30-day lag, so it takes a bit of time. Most often cited, actually, before we get there, so 23 patients died in 2019, 15 actually used their medication, and then in 2020, we see similar numbers. It's really interesting. We see the same statistic in all of the authorized states. There are now 9 states in Washington, D.C. who have all authorized medical aid in dying. And interestingly, there's usually around 1/3 of patients who go through the whole process don't actually take their medication, but just having it on hand gives them a huge sense of relief to know they don't have to worry about what their final weeks and days will be like. So, a patient, once they get their medication, if they don't feel like they need to use it, then they don't. Most often cited underlying illness is cancer. The majority of people who use the law are over the age of 65. They have private insurance. They tend to be white and male. I will say that Hawaii State Medicaid MedQuest does cover medical aid in dying. The average waiting period in 2019, it was between 35 days and 27 days. And in 2020, it was 42 days and 29 days. And remember that 2020 number is still not final. Total statewide access, we know that there are 20 attending providers. That means 20 different doctors who have written prescriptions, 1 on Hawaii Island, 1 on Maui, the rest are on Oahu, and 22 of the consulting providers. On Hawaii Island, there are 3, 1 in Kauai and 1 on Maui, and there are 15 different counseling providers, 3 on Hawaii Island and the rest on Oahu. AP retains the final attestation, no copy to the Department of Health. Ensure consulting and counseling providers appropriately complete, sign, and date the required form. There's only been 1 cited complication related to DDMP2. It took over 6 hours. Remember those red flags that Jake talked to us about? I'm going to keep going a little bit faster because I know we're running out of time, but it's important to note that the death certificate, it lists the underlying illness. It doesn't say medical aid in dying. And encourage training amongst provider groups to increase awareness. That's really important. And the Department of Health website and required forms. The Department of Health has made 2 important recommendations. We know that not every eligible patient's able to access the law. We don't know how many patients because we only get forms for patients who made it all the way through. But the Department of Health has recommended to the legislature in actually now for 3 years, 2019, 2020, and 2021, that first of all, there needs to be a waiver of any waiting periods if the attending provider and consulting provider agree that the patient death is likely to happen prior to the end of the waiting periods. Oregon has amended their law so that, in other words, if the patient's unlikely to survive that waiting period, they still have to go through all the other steps, but they can expedite the process. They also recommend giving access, including advanced practice registered nurses to act as the attending providers for patients. So there was a bill based on the Department of Health's recommendations in the legislature last year that passed through the state Senate and almost through the state House. But unfortunately, when the global pandemic hit Hawaii, the bill didn't make it. It will be filed again. And so these are really incredibly important amendments to make. If you're supportive of the bill, we encourage you to reach out to us. We can let you know when the bill's in committee hearings and you can provide testimony as to why you think these amendments are necessary. I do want to point out advanced practice registered nurses already have the qualifications to write prescriptions for controlled substances. It's just the way that our Care Our Choice Act was written that precludes them from supporting patients in the law at this time. So that's why the law needs to be amended. Back to you, Susan.
Okay, so just great. So just really quickly, I mean, the majority of the patients actually have been seen at Kaiser. Pretty steady between 2019 and 2020, 43 and 42. Again, 80% of those were cancer patients. Pretty split between Big Island and Maui. We have not had any referrals from Kauai. There were 5 that were ineligible, so 3 because they didn't meet that prognosis of 6 months or less, and 2 in terms of the lack of decision-making capability. 39 prescriptions have been written. This is as of December 31st, 2020. 61 deceased. 25 of those were from medical aid in dying. There was 1 suicide, sadly to say. That was a referral received one day, and the next day, when I looked at the chart, he had actually committed suicide that evening. So just in terms of the importance of hopefully changing the law to be able to have the attending waive that waiting period, you can see that if we look at both 2019 and 2020, about 24% of the patients actually passed away in that waiting period. 16% in 2019 and 34% in 2020. And that being said, we've got a pretty tight, organized system, and we're still not being able to, sadly, meet the needs of patients who really want some control over end of life. Next, okay. So just to transition to talk a little bit about 2019 to 2020. We initially developed a task force along with an operational work group. So we've got lots of documents around workflow and policy. We've tweaked it over time. We definitely have gotten better in terms of time from referral to dispensing the medication. We've decreased our time. As I had mentioned before, definitely an improved partnership with hospice. We've had more physicians participate as both the attending and the consultant, and that includes both primary care providers and specialists such as neurologists and pulmonologists, et cetera. Initially, we were only dispensing medication on Oahu. Now we're able to dispense on the Big Island as well as Maui, which has been very helpful. We've seen that going from the DDPM2 to DDMA, time to death has gone from hours sometimes to minutes. So a much easier death, certainly for the family that's in attendance. As I think Sam had mentioned, Quest does now cover. So we've developed obviously a workflow to be able to meet the needs of those patients. And I think one of our challenges is sometimes, and that may just require more education for our physicians, is sometimes we're being given a referral and the patient, as Dr. Grubin said, it's kind of pointless. The patient's going to pass away before we can get.
Susan, I don't know what happened, but you just went on mute.
Sorry. Okay, so just in terms of the timing of the referral, just really important that the physicians, as soon as they feel as though it's a 6 month or less, to send in the referral if that's what the patient's requesting, so that we don't have to, sadly, have patients pass away without this option if that's what they choose.
Thank you, Susan. I'm going to go quickly through the data from Hawaii Pacific Health. We have about 18 minutes left, and I know we still have a lot of slides and questions coming in. But we see similar statistics here, as you can see on this slide from Hawaii Pacific Health. They've had 51 patients, 78% with a cancer diagnosis, 68% had a palliative care consultation, 76% enrolled in hospice. 32 patients completed their first oral request, 24 patients completed their second oral request, and 17 patients actually received prescriptions. They had 11 on Oahu, 4 in Kauai, and 2 on Maui. Their transition story is similar to Kaiser's, as you can see here. It takes time. Medical aid in dying inpatient policy was approved in January of 2019 when the law went into effect. They did lots of education, CMEs, grand rounds. They had problems trying to find doctors who would act as the attending and consulting physician for patients. Leadership involvement. They incorporated palliative care referrals into the program, hospice, pharmacy, and counselors outreach. They had a dedicated medical aid in dying, HPH, intranet, internal communications, which is really important, EMR support. And that was all in 2019. In 2020, more physicians were willing to support patients. I will say it's all about storytelling. Let your friends who are colleagues, who are physicians, know why it's important to be able to support patients in this option. A workflow process was streamlined, lots of one-on-one education with providers, a dedicated presentation, telehealth and telephone encounters. Dr. Goodyear, back to you.
Thanks, Sam. Just very quickly, these are numbers from my practice. And the main point that I want to draw from these numbers, as of the end of December, I had received 45 referrals for mental health evaluations, mostly from Kaiser. And of those, 42 were found to be capable, and only 2 were not capable. One patient passed away prior to evaluation. The point there is that it seems that a relatively small percentage of patients who request medical aid in dying are found to be incapable. And to me, that raises a question as to whether we really need to require all patients to undergo the mental health evaluation.
So why do people ask this? And I think Susan mentioned it earlier. It's a number of reasons, is not one reason, but mostly they want to be empowered to have some control at the end of their life. They're about to die. Their disease is going to take their life, and they want to be able to have something that they can do. And that's really the reason. We're doing a much better job with pain management and in our palliative care programs. And that's the myth out there that if we could do better, if we could control pain better, no one would ask for this. That's not true. There is intolerable suffering. Some of it is not seeable. You know, it's inside the patient. And so they have a diminished quality of life. They have loss of any pleasure. They have anhedonia. So multiplicity of reasons. The main reason, though, is a patient just wants to have some control of their last days. I want to follow up with what Brian said about the capacity question. I think it's really true that many patients who don't have capacity and request aid in dying we don't let them get in the process, so they don't get to the point where they have to see a mental health counselor. So that makes it even less necessary, I think, for a mental health evaluation. And I hope that your state will be able to change that. And Sam, I wanted to say one quick thing. I do know of a case on Molokai that a patient actually used the medical aid in dying medication, and the physician who prescribed it is a Molokai physician. Next slide, please.
Thanks, Dr. Grube.
There is, if you follow the statute, if you go through the steps that we've outlined tonight, there's no risk for being sued. I guess you could be sued, but you're not. There's never been a case that went anywhere with it, and no disciplinary action from the state medical board either. Also, it's important, and we haven't mentioned it, but any healthcare provider does not have to participate in the process of medical aid in dying. And so this is individual choice by the healthcare provider. It does not affect any contracts, such as health insurance or life insurance contracts. That's by state law. It is not euthanasia. It is not mercy killing. It is not suicide. It is not homicide. That's the legal definition of Our Care, Our Choice Act. As I think Sam mentioned, the death certificate should have the terminal diagnosis and not medical aid in dying. And we can talk more about that, but let's move on to the next slide. Really important to note that a number of organizations have become neutral with regard to medical aid in dying. A most recent one is the American Nurses Association, who now have removed their opposition to medical aid in dying, as has the American Academy of Family Physicians, my organization, and the American Academy of Hospice and Palliative Medicine also have a neutral position and no longer oppose this option. Next slide. We've talked about this already. Next slide. So in some summary, in the states where medical aid in dying is authorized, which are up there at the top of the list, we know these things. These are consequences that we sometimes didn't expect. That having the prescription itself is palliative, and we heard that several times this evening. People are using the law not because of lack of pain control, but because of loss of autonomy, loss of dignity, and loss of pleasure. And there's never been any evidence in any state, Hawaii included, that groups, cohorts of minorities, whether they're the elderly, people with disabilities, or people of color, have been coerced into using this or that it's been harmful to them. Next slide. One of the arguments that the American Medical Association has made is that the medical aid in dying has a negative impact on the doctor-patient relationship. On a personal note, and in my conversations with many physicians all across the United States, this is absolutely incorrect. When a physician can have a complete conversation about all end-of-life options with the patient trusts the doctor more than ever to know that they have been given the information and that they can make the choice of what they want to do. So there is an absolutely positive impact on the doctor-patient relationship in regard to medical aid in dying. Next slide. Again, I mentioned this earlier, and I think Susan mentioned it as well. We do have personal beliefs. They're important to us, but they have no place in the exam room. Professional integrity is paramount. We need to respond to requests in a neutral fashion, supporting our patients in choice. And if it's something that we cannot do, then we should refer them to another healthcare provider to talk about end-of-life choices. Next slide. I think Dr. Sharfin is not here, and this is our resource slide. So I think we have just a few minutes for questions, and I'll turn it over to you.
All right, thank you so much, Dr. Grube. All right, let's get straight to the questions. This question is, what does it take to self-administer the medical aid in dying medication? For example, can a paralyzed person self-administer if they are unable to lift their arms?
Yes, I'll quickly talk about this and then I'll ask Chuck to chime in too. We didn't mention it exactly, but it's legal to assist someone, but is illegal to administer. So in that case, a nurse or a family member could hold the cup and the individual could suck the medicine out with a straw. So the dying person has control of intake, starting, stopping, and the family member who's holding the cup is not administering, they're just assisting. So it's legal to assist and illegal to administer. Chuck?
Yeah, I totally agree with David. And I do talk to my patients about that. Say, you know, because it has nothing to do with they just can be so weak that it's hard for them to hold the cup. And I think it's perfectly legal, perfectly ethical for the patient, family, or the nurse, or myself, if I'm an attending as the physician, to hold the cup so that they can drink. I'm not forcing them to drink. I'm just assisting. And I think that's a very big distinction.
Thank you, Dr. Miller and Dr. Grube. Can the consulting physician be within the same practice of the clinic, or does it need to be a completely separate clinic? Dr. Miller?
Well, I can tell you what Kaiser's policy is. They can be in the same clinic. They can be clinic colleagues. They can be, I mean, I do a lot of the consulting physicians for our patients are the primary oncologists for the cancer patient. And they serve as the consulting and I serve as the attending. So same clinic, fine.
All right, Dr. Goodyear, when a patient is given a diagnosis of a terminal disease with no history of mental illness, how do you determine that depression at this moment is temporary or needs to be treated with medications?
I think that some degree of sadness is to be expected in quite a few of these patients. You know, they're just facing the fact that their life is going to be coming to an end in the relatively near future. So some degree of sadness in that situation is not to be not unexpected. But I will say, of all the patients that I've seen, I don't think there's anyone that I've seen so far where I felt there's been a need for medication for say antidepressant medication to be prescribed. The vast majority of patients that I've seen actually have been nowhere near clinically depressed. Some of them I've been really surprised at the fact that they are in remarkably good spirits in many cases. And I've had a couple of patients that have been in mental health treatment prior to making the request. And I've recommended that they continue that treatment. But I haven't come across anyone so far where I've had to say, you know, this is a patient who's never had mental health problems before, but now because of the fact that they're facing death, they need antidepressant medications. That just doesn't happen.
Mm.
And I might add, Sam, we all know that it takes a long time for antidepressants to work, maybe 4 to 6 weeks. And we're talking about these people having days, with the exception of psilocybin, which is a fascinating new research item. But anyway, beginning antidepressants for someone who has days to live is probably close to malpractice.
Mm. Yeah, thank you. All right, the next question is for Jake, I believe. And there's several questions about the medication. Once ingested, how long does medical aid in dying take to work? I don't know if Jake's still there.
I'm here. Hi. Yeah, so once ingested, usually the patient will fall asleep in anywhere from like 5 to 25, 30 minutes. I think a little in between there usually. And then after that, the time to death ranges, but in the majority of the time it's under 2 hours.
Yeah, Sam, let me just make a comment for our experience with 60 some odd, I don't know the numbers anymore, but our experience with Kaiser, the average patient, the median time has been 15 minutes. It's variable. I've had one patient who literally fell asleep within 5 minutes and was dead within 30 minutes. I've also had patients take as long as 45 to 50 minutes to actually fall asleep. And we had the one case that was discussed where it took over 6 hours for the patient to actually stop breathing. So it's we're talking medians and averages here, mostly 2 hours, mostly like Jake said, 15 minutes, but it's, everybody's metabolism is different for how they deal with these drugs. So it's unpredictable. And I talk to the patient, I tell them that when I am counseling them about the medication.
Thank you, Jake. Thank you, Dr. Miller. What happens to the medication if the patient doesn't take it? What if someone else takes it? Do you want to answer that, Jake?
No.
Or Dr. Miller? I can if you want, but.
Well, I mean, okay, so the Kaiser has a very strict, it's not strict, but we give them very clear directions on if the patient dies without taking the medication, what they are to do with it and how they are to manage that. And Susan can probably talk to this better than I am. Nobody's going to take this medication in the family.
Well, and we're talking about patients who have lots of medications that are lethal, probably because they're terminally ill. They have been for a long time. And we do know that, in over 20 years of having this law in Oregon and now 9 states, DC, there's never been a single incident of coercion or abuse. nothing's happened with the medication that shouldn't have. Did you want to add anything, Susan? I know we're almost out of time. I have 1 or 2 questions I'd like to still try to, we might go a
Let
few
me
minutes
just
over.
Sue, let me make one more comment. The patients that Susan and I have attended, the hospice nurses are actually very, very good about taking care of all of the patient's medications, the narcotics that are left over. So Susan, go ahead.
So just briefly, so at Kaiser, when they meet with a pharmacist for a teaching appointment, once they've picked up the meds, they're given an envelope and they're instructed, again, if the meds aren't used, please put them in this envelope and it goes to a federal repository. So that's how they're taken care of.
Thank you, Susan. A quick question. What happened to Cico Barbital? I know Dr. Grube, you like to talk about that. Do you want to answer that one quickly?
Yeah, I don't like to talk about that because it was a single medicine that was very simple and worked much better. Nobody knows is the short answer. It's manufactured only in Canada, and the company that manufactured it quit making it 2 years ago and never said why, and nobody knows.
Yeah. I will say when California passed their law in 2015, the price of Cico Barbital skyrocketed. I'm probably not coincidental at all. No, I don't know. All right. Somebody asked if they will get a copy of this presentation afterwards. Yes, we will send out the recording. If you missed one of the poll questions, yes, you will still get your CEU. Don't worry about it if you didn't answer, or, I promise I didn't ruin the CE for you for the one poll question I skipped ahead. And I think that, I apologize. I know there's a few more questions we didn't have time for, but I think we got to most of them. Thank you all so much for participating today. Thank you to our panelists. We appreciate you so much. Thank you for caring for your patients. Thanks, everyone. Mahalo. Have a good evening.